I'm Dr. Cianferoni. I am an allergist and immunologist. I work at the Children's Hospital of Philadelphia, and I'm an associate professor at the University of Pennsylvania. In my time as an allergist, we changed the practice completely from avoidance of the main allergens until 1 to 3 years of age to early introduction. And this was due to the fact that with the LEAP study, researchers from England showed that early introduction of peanut helped to reduce the risk of development of peanut allergy, especially if the babies were introduced to peanut below age of 10 months and had in their diet until they were 5 years old a good amount of peanut, about 2 grams of peanut protein, 1 tablespoon of peanut butter 3 times a week. And this was particularly true for patients with eczema and other allergies like egg allergies, but it tends to be true also for healthy individuals, and have been shown also to work for egg allergies. And so now, as a physician, we tend to tell the parents to introduce a solid food between age 4 and 6 months, and to introduce all the main allergenic food, especially the one that they are enjoyed by the family. We also encourage families to cook their own food and have a various diet in the children. The IgE-mediated food allergies are definitely the most common food allergies, and the advancement in the diagnosis is that we have more and more tools available to measure the IgE and the response of the cell to specific food through the IgE. So now we can measure the total IgE specific for a food, but also then the IgE to specific molecule that can tell us more if the allergy is true or not. We have also the ability now of seeing if those IgE activate important cells like basophil and mast cell with the basophil activation test and the mast cell activation test. Although these tests are still limited in their availability and often require a more coordinated handling of the sample because they need to be transported to the lab more quickly. For the non-IgE-mediated food allergies, unfortunately, clinical history and empiric diagnosis are important, especially for food protein enterocolitis. For the eosinophilic esophagitis, we still rely on the endoscopy and the biopsy with the measurement of the eosinophils. However, non-invasive method like the string method or the sponge method to obtain a sample for the esophagus are becoming more available, and so will allow to reduce the reliance to the endoscopy for this disease. Unfortunately, for eosinophilic esophagitis, there are known biomarker peripherally that we can use. So one of the advancements that we have had in the past 15 years or so is the ability not only to measure the total IgE for a specific food, but also the specific IgE towards a specific protein containing the food. And so this has helped us because, for example, for the peanut, there is usually available a panel of about 5 to 6 6 allergens that can tell us which, if the patient is more at risk of acute severe reaction. So the ability of measuring the IgE against specific part of the peanut and help us, because the peanut have multiple proteins. So the RH2 is the molecules that name the storage protein of the peanut. This storage protein is very abundant and very resistant to acid and cooking. And so if you have high IgE against the RH2, you are at higher risk of having a true reaction to the peanut. On the other side, if you have IgE against the RH8, which is a part of the peanut that cross-react with the birch pollen, you are less likely to have acute reaction because this protein is not stable and get dissolved by the acid, and is also low in quantity in the peanut. And similarly, if you have IgE against the ANA3 for cashew, or core A14 for the hazelnut, you are at higher risk. And there are some cutoff of level that usually above 2 for these allergen is considered very specific for acute severe reaction, and can save to do food challenges, especially in non-safe place with available in a hospital close by. So the the sensitivity and specificity, which is what is a test, is truly showing the clinical significance of food allergy. In food allergy still, in IgE-mediated food allergy, still strongly correlated with the clinical symptoms. So that's why we suggest to use to measure the IgE specific for a food only if there is a history of clinical reaction to that food. If testing are done without a clinical diagnosis, meaning that the food has never been eaten, then if the test is positive, then a molecular testing or a basophil activation test may help to see to increase the understanding if this allergy is true or not. If the level of the IgE against the molecules, even against the molecules, is still lower, and it's possible that we need a food challenge to prove the clinical reactivity to the food. Unfortunately, or with all this testing, you just assess the risk, but the testing are never 100%, and the gold standard is still considered a food challenge. Often the management of food allergy require a multidisciplinary team because there is a need to support patient nutritionally. So with the nutritionist, if they have multiple food allergies, in non-IgE-mediated food allergy, especially where often the symptoms are gastrointestinal, the support of a gastroenterologist, both for the diagnosis, like in eosinophilic esophagitis, but also to rule out other gastrointestinal diseases that may not be triggered by food and could cause the symptoms of the patient. Dermatologists are often involved in the treatment because patients with food allergies have eczema. And psychologists are often indispensable because these patients have a high level of anxiety due to the restriction and the danger that food presents to them. So the primary care physician may now diagnose better the food allergy by looking at the IgE if there is a suspect, although we strongly recommend to not do IgE to all the foods. The food that the patient is eating, they should not get tested and has no symptoms consistently. If then the IgE is positive, but the positivity is not strong, or the clinical symptoms are not reliable, then a second level of testing, like the molecular diagnosis or basophil activation test or food challenge, may be required to prove the allergy. And often a specialist is better suited in those more difficult diagnoses. So for the non-IgE-mediated food allergy, there are medication and biologic that can be used beside the diet. This is true for eosinophilic esophagitis. For the IgE-mediated food allergy, the current guidelines say in the United States to avoid the food and have available epinephrine in case of accidental exposures. Epinephrine works, and there are self-injectable epinephrine because it blocks the effect of the histamine quickly. So blocks the it makes your blood pressure goes up and reduce the asthma symptoms and the gastrointestinal symptoms. Antihistamine are not recommended for food allergies for the prevention or treatment of severe food allergy because they not reduce the risk of lethal reaction or near fatal reaction. Oral immunotherapy has been used more and more for the treatment and reducing the risk of food allergy. There is one product that is approved for the use of for oral immunotherapy for peanut for children between 4 and 17 years of age. It is approved to reduce the risk of accidental exposures. Only some physicians that they're registered in the REMS system can dispense the medication, and patients need to be on the medication for 3 years. Oral immunotherapy is associated with risk of developing eosinophilic esophagitis, as well as acute reaction to the food at any stage of the immunotherapy. And the long-term safety is unknown because only 20-30% of patients are truly becoming tolerant through the oral immunotherapy, meaning that they can stop eating the food and still not, and when they eat the food, they maintain the tolerance. For the other, if the food is stopped, the allergies come back. There are new therapies that are in development, like to reduce the risk of acute reaction, like biologic, or other form of immunotherapy that they are not oral to reduce the risk, like sublingual or epicutaneous. Omalizumab, which is a biologic that reduces the level of all the IgE, has been shown in several studies, but more recently in the Outmatch trial, to increase the threshold of reactivity of many foods. So it looks like it's providing a increased safety for accidental exposure to a variety of foods. Other biologic in development is ligelizumab, which is another type of anti-IgE. And in a phase 1 trial has been shown to reduce the level of skin prick testing. And this is similar to the data that has been shown in the phase 3 PEARL trial on chronic urticaria. So biologic may come soon to help manage the risk of IgE-mediated food allergies. The shared decision-making for food allergies becoming more and more important because until now, patients had no choice besides food avoidance. Now that there are other options, it's important that the patient discuss with the physician those options to decide which one are more effective and practical for their lifestyle. And those choices may change towards the lifetime, and so continuous follow-up with the physician to decide the proper management in the specific time frame in the life of an individual is important.